Got it. We know that here in Vancouver Coastal Health, we do a lot of wound care. So here in, I can get that to move my statistics. Do I need to press a button? Got it.
No. Was it this?
There we are. Charlene, can you go back a slide?
Okay, I wasn't sure. I was like, I don't see statistics. Okay.
There we are. So we know that here in Vancouver Coastal Health in 2024, so just last year, we saw in home health, just home health, more than 6,000 people who needed support for wound management. That translated, and to Charlene's point, to almost 200,000 nursing assessments were documented for those patient care. And that resulted specifically around 13,000 wounds. So we know here nurses are taking care of a lot of people requiring wound management, and there is a lot of data. Go ahead. So let's put our research hat on. And one of the things we know with artificial intelligence, depending on what machine learning or natural language processing, whatever element we're thinking about, often requires coding. And so we're very lucky internationally to have international code sets that have standardized the clinical terms with a clinical code that can be used across many organizations, many languages, because essentially we're thinking about the code. So we know that's important for artificial intelligence. So one of the starting points that we asked is, you know what, is nursing wound care well represented in these coding sets? Has anybody here heard of SNOMED CT? Some people have. So we wanted to explore SNOMED CT, this big international code set of clinical terms and codes that we use for various other things as well, interoperability, reporting, and as a building block for AI. So we use our BC nursing standardized wound assessment flowchart. So if anyone's ever used Pixelaire, if anyone's used those old paper forms, and more or less what the Cerner iView has, we'll be using the standardized assessment. And so we took all of those clinical nursing terms and evaluated it in SNOMED. It did pretty good, but there were some big gaps. One of them I found interesting was there at the time wasn't a code for a maintenance wound, where the goal of care was to maintain the wound. There was maintained and other kind of elements within maintenance wound, but the nursing specific collaborative goal with that patient to maintain the wound was missing. So just as one example. Then Charlene and I worked together and we decided, let's look even farther. Let's look at some specific wound infection concepts. From a nursing perspective, is there good representation of wound infection in SNOMED CT? And there was sort of. But I want to show you, I don't know, it's kind of hard to see. There's a blue box over there. Can I walk over? Can you hear me? Online. Okay, so just those of you online, local infection of wound. Synonym, septic wound. You know, septic wound, local wound infection, same thing. But SNOMED says they are. Is that a problem? Yes. So these are the types of things, having that nursing knowledge, that foundations of our practice, looking into how at the very foundations, people who use technology, build AI, are using these codes. We want to ensure that it accurately represents our work. And so this was some of the foundation to kind of the subsequent steps of us achieving that goal, or hoping to achieve that goal of nursing prediction algorithms. Next screen. Okay, this one is very neat. If you think about studying or taking one article to read after this, this one could be it. But, you know, I'm a nursing informatics person, so it's cool to me. What we also know is that nurses are with patients. We are highly skilled at assessment and surveillance. Put your hand up if you've cared for point of care patients. Have you ever had that feeling? You're like, something's not right. Now the blood work's okay. The vital signs are okay. Some of the big, maybe recent tests the patient had were okay, but you're thinking something's not right. And you're knowing that because of your years of experience, and or maybe you've cared for that patient for a few days. Is that kind of ringing a bell? Some of you are nodding. So what are the things that you might have been doing? Maybe you've kind of done an extra set of vitals. Maybe you wrote a few extra notes in the chart. Maybe you thought, I'm going to do another kind of head to toe assessment. You are preparing your assessment to try to find something or to observe something that might be changing quickly for that person. Now, when we look at early warning systems, so some of our electronic health records might have early warning systems for sepsis. They're often trained to look for big or kind of moderate changes in vital signs or blood work or some of the other tests the patient have. But this is this is before those things are changing. And so what this concern group out of Columbia in the US is doing is looking at the signals of nurses charting. So they are looking at things like irregular times of doing vital signs. It is looking at increase. Maybe you had 3 lines of charting, but for the last 2 hours, you've had 4 lines of charting. Maybe you've added more PRNs, or you've used less PRN medications for that person. So these predictive pieces are being fed into some machine learning, and it's predicting patient deterioration often better than our traditional early warning systems that may be in place. And I'm going to pull up my notes because there's some interesting statistics I wanted to ensure I said. So their recent study, they did a randomized controlled trial, which in nursing, that's not always common. Okay, it's taking a while. Maybe, Charlene, you can give me the stats. And they published in Nature Medicine, which is a very, very highly rated journal.
Yep,
Charlene, do you
I can
have the
go through the
statistics?
stats. I do,
Yeah.
yeah. So this, so basically what they did is they kind of made computable all of these signals of, what nurses notice when something is off, and kind of used it to build a machine learning model to predict early deterioration. And so the stats are, they achieved 36% reduction in mortality risk, 1-day reduction in length of stay, and 7% reduction in risk of sepsis. So this is, I think, hours, or I think it's days ahead of other kind of more widely used early warning systems. So really demonstrating the value of and being able to quantify that nursing expertise. If there's a way for us to enable that for AI, it brings so much value that is otherwise kind of unused, basically. And in my view, what made this possible is that the 2 leaded researchers on here were nurses, are nurses themselves, one having been an ICU nurse for a large part of their career. So they knew that when you notice something's off, that means something. It's hard to kind of quantify that, but they were able to build that into this model. So this is a really, really nice example.
All right, let's go to the next screen. All right, so this is my dissertation work, which those of you online, we can't share because it's embargoed and yeah, not quite yet published. But this is what then we took forward. So from, again, knowing what's happening in the field, knowing wound care representation and nursing knowledge is really important. I was interested in building what's called a computerized ontology. So this is like a 3-dimensional model that is used in different forms of AI, sometimes the knowledge layer with which let's say the predictive algorithm is pulling to or pointing to calibrate and determine if whatever you've lined it up to is or isn't localized wound infection. And so what did I do? I went to the literature and I found some concepts. No biggie, right? Erythema, induration, increased drainage, etc. But I was curious. I wanted to know, so those perhaps are the more obvious ones, and we know also in the literature some of the subtle ones, but what were the specifics that nurses were seeing as those early first indicators or those early signs of localized wound infection. And so after a series of interviews with nurses from across BC and some nursing wound care experts using rigorous research methods, qualitative methods, I did interpretive description as the broad with different various methods of data analysis. We found that there were about 52 high-level wound infection concepts that were important to nurses, 38 wound infection assessment concepts, and a lot of synonyms. We found, and again, maybe not surprising, that nurses use descriptive words. So there's a couple quotes here. I like this one. So when describing erythema, I usually see it as bright, like brighter red. I say candy apple red when talking to people. And so we might see some of these in the notes, in the charting. We also know that nurses often need something to compare it against. So when I think about those early signs of infection, I might say, you know what, to my patient, a couple of days ago, did you have more pain? They're like, just a little bit. And so you can, again, you're comparing what was known to what is current. Sometimes we compare limbs. If there's a concern on one limb, let's compare. Color and warmth, we will compare. And so taking all of this into kind of understanding how AI could be refined and tuned to nursing needs, this is telling me that nurses have good, complex knowledge of wound care and wound infection. Nurses use a lot of descriptive words. So if we create any sort of model using nursing knowledge, we need to ensure it's broad enough to allow synonyms and descriptive words, and that we need something to compare it against. And that can go into many things like the trust of AI, being able to reference previous charting. And so when we create algorithms or decision support or analyses with natural language processing, we want to consider these sorts of things. It's beyond the word that we found in the literature. It's much more complex and contextual. Is that aligning to, yeah, it makes sense. But it's not obvious when you talk to everyone who creates different forms of AI. This is why that nursing lens is important. All right, Charlene. Oh, and yeah, that is another angle. That is that one single idea of wound infection. All of those are concepts and the relationships. It's a 3D model, so you can ask it to show different views of it. That's just one view.
Like a multiverse type situation of synonyms. Right. And now I'm talking about community nurses and kind of nursing role and expertise really in looking at in health equity, advocacy, social determinants of health assessments and these kinds of things, right? So these are the things that nurses are really good at, relational care and that kind of thing. And so as Lori was progressing in her PhD work, I was also just starting up my role at UBCO Okanagan and kind of starting up this research program. So my interest is really in the intersections of health equity and technologies and kind of looking at AI more recently. And so, the kind of focus on community nurses really came to me partly because of community nurses, home care nurses, really having that lived experiences or seeing the lived experiences of how social determinants of health and how health equity factors show up in the daily lives of people. So this slide here is talking more about the literature. So we know that the literature is limited in terms of what evidence there exists for different groups of people. So you'll see that kind of changing photo there. This is a book that was actually created by dermatology medical resident fairly recently, like within the last 5 years, I want to say, in the UK, because he noticed that there wasn't much instructional material for people with dark skin or, darker pigmentation. And so kind of a little bit shocking, but not really. That kind of, this is still the state of the medical literature, is that we're still missing huge swaths of people because of the nature of how medical evidence has been built, right? RCTs are by design needing to be exclusionary because they need to tightly control to make sure that the effects that they see are actually the effects that they see and not due to confounders. And so what happens in a lot of designs, at least historically, is that a lot of groups that are too complex to control for are just excluded. So these are, the larger groups are older people with multimorbidities, right? That's too complex. We're going to control them out. A lot of children, younger people. Makes me angry, but not that surprising. Women, because hormones are difficult, apparently, for, I don't know, 50% of the population is excluded in a lot of these RCTs. Yes, yet this is the evidence that we kind of generalize across the population. And so the other little snapshot that you see there is, what we're learning, like embarrassingly, just now around cardiac arrest and differences in symptoms between sexes. It's still just coming to light, and we're starting to just acknowledge now that, like, hey, actually, this looks different across different biological sex. So knowing these limitations of the literature and knowing that community nurses like actually, show up in people's homes or have that really firsthand view of what neighborhoods look like, what relationships look like. For me, that provided another entryway or another way to see how social determinants show up. That is not just kind of these theoretical definitions of social determinants of health. Like, I think we all know those, like the textbook definitions, but how does that actually show up, and how does that actually matter for care? That's kind of the driving force of a lot of this work. And so in order to understand that, and I promise this leads into kind of the machine learning AI stuff a little bit later on, one of the first studies that we did was just trying to understand these definitions of how community nurses conceptualize health equity in practice. And anecdotally, we knew that this wasn't just the textbook definitions that we saw. And this was what we confirmed in these interviews that we had with community nurses. So confirming that, yes, social determinants are important in the care that they provide and in their care planning. However, their definitions were a little bit different than the textbook ones, or a little bit more complex in terms of how they showed up. There's a large variability in how nurses saw and thought about social determinants of health and how much of a role that played in their care. So, for example, some nurses would say, yes, it's really, really important, but I know I can't change anything about their housing. And so, I don't want to ask all of these really intrusive questions when I know there's nothing I can do about that aspect of their lives. And so there was a real kind of range in terms of people's comfort with asking about this, in terms of people's like approaches. So we found that, nurses who were more experienced were a little bit more comfortable asking about this, about social determinants of health, or if they felt like maybe they were in a position to direct people to more resources, they would be more comfortable. It was also really interesting. Some of the things nurses talked about were, saying things like, I know I do a really comprehensive assessment of social determinants, but I'm not sure all of my colleagues do, or I don't see in all of the notes that it's always that comprehensive, and it really varies a lot. So that was really interesting. And I think a lot of it we knew, but we had to kind of confirm, because this is the structure of evidence and the literature and that kind of thing. Importantly, one of the key things that we also asked in this study was asking about where people documented social determinants of health. So electronic health records, for anyone who's ever used them or even has just thought about them, know that they're notoriously not great at serving clinical needs. And so again, this was, something that we confirmed. And so in particular, with the documentation of social determinants of health, I think there's like 3 data fields where social determinants have captured, which is like age, biological sex, which was binary option, postal code. There's other fields like relationship status or things like that, but those are really, really inconsistently completed. And for the nurses that really valued or said that they valued assessments of social determinants of health, because there was no clear place in the electronic health record to record this, they told us that, like, I put it in the text notes and the narrative notes because there's nowhere else I don't know to put it in. But then the problem is, like, it just kind of goes there to die and nobody looks at it again, besides maybe the next clinician if they were specifically looking for that. But otherwise, there's no ability for us to look at trends, to look at any kind of population or group level insight. And so the question of, and this is not just specific to this one organization, this is unfortunately true across a lot of health organizations, like globally, is that because there aren't places for nursing documentation, for documentation that matters to nurses to live, what does that mean for the possibilities of what we can do with AI? Like if our data aren't there and in a way that enables us to use it, it really limits the possibilities. And so, as I mentioned, this is like known across the world. We are not unique in BC or anywhere else around EHRs being poor data sources, especially if we're thinking about developing machine learning models or AI models. We also confirmed this just broadly in the literature. So this was a couple of years back now. Lori and I were part of a group that worked on a rapid review that looked at publications that had specifically used nursing or allied health data with AI developments, and they are not really there. People are not using them because they're messy, and they're messy because EHRs are not set up to capture them well. So we're missing a lot of expertise that nursing and allied health have, relational care, patient advocacy, social determinants of health. Like these are things that could make these models better and more equitable, but we're missing them all because of how we've built the infrastructure around this. So the kind of there's all that background work and just this to give you an idea of kind of what this is all going towards. And Lori and I went back and forth about how to best present this. I'll do my best. So this is part of kind of a larger series of work around trying to establish, how do you build an AI model that is driven by nursing needs, that are built by nurses for nurses kind of thing. And again, our kind of proof of concept case is trying to predict the early wound infections in communities. So what does that entail? So first is kind of, actually, before I go into that, so what we want to do with this model, so, that's fine, whatever. Lots of places develop predictive models that go into clinical decision support tools. What we wanted to do was different was identify, not just the clinical data that are important for wound infection risk, but also the nursing expertise, in particular, social determinants of health, patterns of care delivery, things like referral. So all of these other kind of peripheral things that we may not necessarily, or maybe somebody without a clinical background may not necessarily think about as relevant. We wanted to incorporate those. So that requires us to actually mine the notes, those text notes that otherwise go to die, and see what we can pull from those and how we can pull that out. And part of it is we want to demonstrate that, like, hey, maybe we need to shift how we document so we can actually use the nursing data. That's really, really useful. So in terms of translating to like machine learning speak, we needed multimodal data. So we need structured data, we need text data. We're hoping to incorporate image data as well, so pictures of wound images. So now back to kind of the steps of this, to what needs to happen for this to happen. So first is that foundational piece of identifying what are social determinants of health as defined by clinicians, and then what is wound infection risk as defined by clinicians. We have those synonyms now, and we have some of the wording around that. That's great. So now we have a dictionary that we can train a natural language processing model to mine the notes for. So it's going to look for all of our synonyms of social determinants of health, all of our synonyms of, different ways that you can say or assess wound infection risk. So that's kind of one part of it. Another part of it is building a machine learning model with just the structured data. So just the data that we normally input without any of the text data. How does that perform in terms of wound prediction risk? And then the final step is then adding in that text data into the model and seeing how much better, how does it change the prediction performance? Does it make the prediction of wound infections better if we incorporate the text data from nurses that talk about social determinants, that talk about kind of these more nuanced ways of understanding wound infection? Or maybe it doesn't, but we won't know until we kind of figure that out. Other studies that have done kind of similar steps have shown that yes, adding the text data does make a difference in improving performance in particular. I don't know if you want to add anything here, Lori, before I go to the next slide.
Maybe just a call out. We know research takes many hands and a lot of work. And so while Charlene and I have been privileged to lead much of this work, this health authority and UBC have contributed significantly. Just to call out, the data that is both structured and unstructured that's being fed into this work comes from our community VCH EHRs, Harris and Pixelair. That extraction of that data and protecting that data for de-identification was done with the data and analytics team. One of the first examples we were able to pursue with using different scrubbing techniques of natural language processing to ensure that there was no names or clinicians or patients in the pretext that we were giving to UBC for this modeling. Our IMITs, primary care community team, spent many, many hours building and helping us understand the database data dictionaries. We had VCHRI in this work and many others. So just to call out, I know many of you here are part or doing research. You know how many faces, how many hands it takes. And this is like driven by clinical need and ensuring that our clinical voice is part of this work. And so again, just that big call out and thanks if anyone's on the line or in the room. Thank you if you've been part of this work.
I'm gonna skip that other one because we're running out of time. So I'll pass it back to you here, Lori.
And so what have we learned about nurses and AI? And this is just our personal reflections. Being around in the early 2000s, we had Facebook, right? So it's complicated. We're in a complicated relationship, but it's not bad. What we know about innovation in AI, we know it's complex. We're going in with eyes open. We know that it can represent our nursing knowledge. What we share today from our own research and from around the world is just the start and more to come. And it takes time. As I mentioned, at least for Charlene and I, we started this work in 2012. And we're just getting to that results where we're able to see, I know we're not showing it right now, but we're starting to see the early results of prediction modeling. We're starting to see how nurses are charting those early indicators and how it can be enabling us to help, predict maybe infection in the future. By the way, I think Charlene and I were joking. In that time, I had a baby who's now a teenager in high school. I've had another baby, and Charlene had two, so it takes time.
Been many babies long. Right, and to Lori's earlier point, so much of this is relational. So it's all so many things beyond just the technical development. So live relationships that we have had to build and kind of manage and just understand in terms of things like how the health authority timelines work in fiscal years and all of these things that you don't think are going to be a part of it, but really play an important role, and structural as well. So there's a lot of conversation, not just within this study, but just broader around, legal requirements and data sharing, and what role does that play in innovation in Canada broadly? And, what does that mean for what we're able to do here versus elsewhere? And so it's a lot of work. It's like at least, 3 babies long to do this stuff, and we're just getting started. And so, the question for me always is like, so why bother with all of this effort? And I think the short answer is like, this is the difference doing this work between something like the concern algorithm and something that's developed by vendors without or limited or unknown inputs that are rolled out without consultation. So concern similarly, I think took at least 15 years, but the impacts you can see are really clinically relevant. They've kind of thought about the things that are important to clinicians. And then unfortunately, there's lots of stories about just like these proprietary models that have been developed and rolled out and they're not good and like all of these issues. So that's the difference in terms of, at least that's how I justify to myself why all this effort is worth it. And so I'm going to skip the video slide, Lori, and just kind of go into thanking everybody for your time here. Like Lori has mentioned, so much people, so many people and funding and infrastructure and like relationships have gone into making this beginning step. Really, it still feels like that possible. So we just wanted to give a shout out to everybody who's ever supported us. And I know I'm staring at some faces in the video who I'm thanking kind of in spirit.
Awesome. Thanks, guys. Thank you so much for the talk. Don't go away. I think we might have time for a couple questions, and then additional questions you can always send to us, or Charlene has put contact info there for Charlene and Lori. If you have questions, feel free to reach out and email. I might start with the chat. Tom, do we have any questions in the chat? Oh, good. Thanks, Charlene. Any questions in the room? Yes, Katie.
So when do you think your research will be published? And what are the implications for home health with that predictable? Anticipate the outcome of that. I think my advisors are also asking when is it going to be published? Yeah. Well, I know for my dissertation work, my goal is to be at least submitting to journal for the summer. So let's hope for fall. Charlene, do you want to add any commentary around the prediction models that you're working on right now?
Yeah, so we're cleaning up. So we ran some prelim. I was hoping there might be a little question. So I'll show you some prelim results of early models that we have here. So we basically, you took 3 years of data from 2 electronic health records in the community here, so the wound care and the Paris community, to see predictions, predictors of antimicrobial use. And so these plots are, they're called SHAP plots that show kind of which variables are the most important in predicting antimicrobial use. And so for this study, we ran like 7 different kind of machine learning models to see, you know, which variables are coming up as the top predictors kind of thing. So since running these analyses, we've noticed some stuff that we need to clean up in terms of the data quality, and we need to kind of recode, do some more encoding of variables. So there's a cleanup process that's happening right now, but that paper should be submitted sometime in the summer. So you'll see, I'll just kind of walk through. So I don't know if anybody's familiar with SHAP plots, but it's a way to try to make these machine learning models more explainable. And so you'll see a couple, I don't know if you can see my arrow moving around here, but the feature value. So the color is what indicates how important a variable is for that particular prediction. So here, the more, I don't know, hot pink, red color indicates that's really important predictor for antimicrobial use in this particular model. And then the direction shows whether it's a positive predictor or a negative predictor. So you'll see differences across the different models in terms of what they pull out as the most important predictor, right? So this model called TabNet, here it's showing that like clients changing their own dressings daily is a positive predictor of antimicrobial use, whereas in the light GBM model, you'll see that wound bed eschar is being dry and stable is a positive predictor of antimicrobial use, et cetera. And so these are kind of ranked. We're also working on better ways of visualizing these. They're a little bit more intuitive. But you can see where there are kind of common things or common features that are coming up and differences in features that are coming up in these models. So yeah, there's a bit of a kind of sneak peek at some of the things that are going to happen. I wanted to clarify too, I didn't get into it, but I guess in talking about AI and these models today, we're talking about machine learning and models rather than kind of generative AI, which is dominating a lot of the conversation right now. So just to clarify that.
Awesome. Just a huge thanks again for both of you for being voluntold to present. It was very nice that you said yes. And thank you for sharing your work with us. I think we have a bit of a 10-minute break. So folks that are here in the room, apologies for folks that are online. We do not have coffee for you, but there is some coffee outside if you guys wanted to fill your glasses, and then come back right on the hour, and we'll proceed with our next couple of talks.
And just a really quick plug, we had a lovely donation by Figs for a Figs gift basket. It's there for viewing if you want to see what you could be able to win. But this QR code leads to an evaluation survey for the event, and at the end of the survey, feel free to submit your email for a chance to win the gift basket that was donated by Figs. And then all of the coffee and treats were donated by Nipro, a sponsor, and they have a table outside. So go and learn if you want. And then we'll start promptly at 1 so we can, somebody's head is just blocking the camera up there, but that's okay. We'll start promptly at 1 and try and keep on track. But go have some coffee and then we'll be back for 1.
Health and substance use. And we're recording. Good. Thanks, Tom. And she provides clinical practice leadership to that program. Today, she's going to be presenting on her research study examining clinicians' experiences using a mental health and substance use screener in the community setting. So a warm welcome to Sue.
Good afternoon and happy Nursing Week. So I'm here today to talk about nursing research and implementation of a mental health and screening tool in a community setting. So a clinical nurse specialist is an advanced practice nurse in an area of clinical practice. For me, it's mental health and substance use, and is a leader. One of the roles of a clinical nurse specialist is a researcher and to ensure that their practice applies evidence-based care most effectively while being a leader in every aspect of research. So why do research? Research generates new knowledge and insights into clinical practice by identifying new approaches to client, patient, and resident care. Research can also help to identify and address gaps in care, leading to better client, patient, resident experiences and outcomes. It's important to use evidence-based practice to support evidence-based research to support practice, so we can reduce variations in care by standardizing procedures based on evidence, as well as reducing reliance on outdated information. So I'm just going to talk about the background of the study. So mental health and substance use disorders significantly impact individuals and communities in British Columbia. Approximately 1 in 5 individuals are impacted. It's important to have early identification and intervention to prevent worsening symptoms and to make appropriate and timely referrals. Within VCH, Mental Health and Substance Use Program, screening practices lack standardization, leading to variances in clinical practice. In 2019, there was a regional concurrent disorders steering committee, which had a survey, and they reached out to acute, community, and tertiary settings to find out what screening tools may be utilized or what their screening practices were. And the survey highlighted these inconsistencies and the need for standardized screening tools. So what happened was that the Regional Mental Health and Substance Use Program decided to adapt from the GAINS SS, or the Global Appraisal of Individual Needs Short Screener, which is a validated tool. What they did was that there was an existing substance use assessment tool that was found in Paris and EMR, so these are the clinical information systems used in community settings, adapt from there, add additional questions with respect to mental health and substance use, and then they called it the VCH MHSU screener. A team was formed wanting to do research on the VCH MHSU screener, and our team applied for a Vancouver Coastal Health Research Institute team grant application and was approved. So the study team. So the study team consists of myself as well as Mohammed Ibrahim. He is a nurse. He's also a social worker and he's an assistant professor at the School of Social Work at UBC. Also, Cato Francis, who's a PhD student and research assistant, who's here today in the audience, who's with the UBC School of Social Work. I just wanted to just highlight What was unexpected when we got this team grant was that we had a pandemic, and no one knew that a pandemic was going to come, and the impact that a pandemic had on individuals. And so what happened was that we actually had an original study team, which included several valued members whose contributions made a significant impact before their roles transitioned during the pandemic. So we had folks who were part of the original study team who, moved geographically. If you think about where you were with the pandemic, you saw some folks who were like, I'm going to move to another area because maybe it's better as in terms of quality of life, thinking about, where they're at and so forth. Also, as well, what we didn't realize was having a pandemic would actually impact our original design that we had for our study. So we lost some of our initial study sites. However, this challenge provided us with an opportunity to adapt our approach. So we were successful in simplifying the research design, which allowed us to focus our efforts and enhance the impact of the completed study. So screening. Often screening and assessment are seen as the same, but they actually have two very different functions. So screening is really a brief initial evaluation to determine if further investigation is needed. So if you think back and, back when we had a pandemic, you'd be asked questions being like, oh, have you traveled in the last 14 days? Do you have a fever? Do you have a cough? Do you have chills and so forth? Simply, you would answer yes or no to those questions. Versus assessment's much more complex evaluation to understand the nature, severity, and the complex of a potential problem. So for example, if a respondent answered yes to any of those COVID screening questions, further questions would be asked to learn more. For example, if someone said they had a cough, further questions might be like, how long has this cough been going on? Is it constant? Does it impact other areas of function? So I just want to lightly touch on the GAINS SS, which is what the VCH MHSU screener is adapted from. So the GAINS SS itself, it's a validated tool. It's a screener used in general populations to quickly and accurately identify individuals who would be flagged as having one or more behavioral disorders, internalizing disorders such as mood, anxiety, suicide, and hallucinations, externalizing disorders such as ADHD, aggression, conduct disorder, or gambling, substance disorders, and crime and violence. It's important to note with the GAINS SS, there is a manual on how to administer and score. So what does it mean if there's a moderate to high score on one of the behavioral health disorders? And the manual would indicate what the typical treatments may be. And often with the questions asked in the GAINS SS would be asked in a time frame of when the problem last occurred. I think I have to. Sorry.
Oh, you can see it on ours here, maybe.
I can't see it up there, but I can see it here. There, perfect.
And then just go back to
Go
the
back to
slideshow.
awesome.
Yeah.
Thank you. So this here, I'm just showing you, this is a hard copy form of what the GAINS SS looks like. So all the questions, they're answered based on time frame of the past month, the past 2 to 3 months ago, 4 to 12 months ago, 1 to 1 year ago, or never. And then with internalizing disorders question may ask, when was the last time you had significant problems with X? So for example, feeling very anxious, nervous, tense, scared, panicked, or something like that was going to happen. An example of an externalizing disorder question would be, when was the last time you did the following things 2 or more times? So for example, lied or conned to get things you wanted or to avoid having to do something. And with respect to substance use, when was the last time you used alcohol or drugs weekly or more often? And then with respect to crime and violence, when was the last time you had a disagreement in which you pushed, grabbed, or shoved someone? And then with the GAINS SS, there's a few other questions, just asking more demographic information about, gender, age, how long did it take to complete. And at the bottom, there's a section for scoring for the person who's been recording the information. And then with the manual, they will be able to score appropriately. So as mentioned, what What the regional MHSU program decided to do was to create their VCH MHSU screener. So they've added questions to an existing substance use assessment that's found in Paris and Profile EMR, which is a minimum reporting requirement. So these are data points that the health authority reports to the ministry. I'm just going to do a demonstration of that. So here I have a hard copy of what the screener would look like. So with the screener, it would ask, the first question to be is the client currently engaged in mental health services? If the client answers yes, then you would move on to the substance use screener portion. If they answered no, then the clinician would proceed to the second question. Are you or someone in your life concerned about your mental health? And then the following questions would also be asked, and the client would be asked to be able to rate it is in terms of timeframes of all the time, some of the time, none of the time, or unknown. So for example, like, have you been feeling anxious or panicked, or have you been having troubles with sleep? And then there's a question where it asks, has your mental health impacted your work, school, social life, family, home, and responsibilities? And there's a section for information to be entered, more narrative, if the individual is involved with a service, have been hospitalized, diagnosis, and so forth. With respect to the substance use side of the screener, so it asks if the client's currently engaged in substance use services. If they are, then the following questions wouldn't be answered. If they answered no, then would proceed to the second question, are you or someone in your life concerned about your substance use or alcohol use? And it would ask the same questions similar to the mental health side. Has your substance use impacted your schoolwork, social life, or family home responsibilities? And then there's a question asked about, in the past 6 months, have you experienced an overdose? And then and asking which substances the individual may have had an overdose. And then asked also, have you ever been treated with naloxone for an overdose? This section here is the actual they call it the substance use assessment, but this is the minimum reporting requirement, which is the base of which this VCH MHSU screener was adapted from. So where clinician would ask, do you use any substances? If it's not assessed, not identified, but if the client does answer yes, then they would indicate what the route is. There's a drop-down pick list, the date the substance was last used, the date in which the substance was used in the last 30 days, the typical day in which the amount was used, age at first use, current pattern, and stage of change. And then it would also ask if you could tick if the individual is using over-the-counter drugs, prescription drugs, other, and so forth. And the last section is where there could be information that's documented about the substance use, if they're involved, the individual is involved with a service, detox, hospitalization, diagnosis, and overdose details. And the last part of the screener is the recommendations and plan. So where the clinician can tick any of the following recommendations: if they decline service, follow up with GPNP, refer substance use services, mental health services, one-to-one individual counseling, group-based services, bed-based services, and internal, external services. And then just note who provided this information and such. So the study. So the objectives of our study was to evaluate the clinician's experiences with using the VCH MHSU screener and assess the screener's impact on service and referrals, and lastly, to identify gaps in the screener usage. So methodology. So our study site was the Access and Assessment Center, which is located here at Vancouver General Hospital. The Access and Assessment Center provides a myriad of services, which includes referral intake, on-site assessment, crisis intervention, and short-term treatment. Their services are provided by phone, in the office, virtually, or by outreach. They also perform mental health and substance use assessments, referral to VCH, mental health and substance use services, information and support to access VCH addiction services, admissions to VGH inpatient psychiatry, and crisis intervention and support. It's also important to note that the Access Assessment Center was actually the pilot site that first started using the paper version of the MHSU screener before it was developed and implemented in Paris, the clinical information system that the Access and Assessment Center uses to document. As in terms of methodology, we promoted the study at the huddles, and consent was obtained from participants. The interviews were conducted mostly in person and then also by Zoom. Thematic analysis was guided by a co-book to analyze the transcripts. The questions that were asked of the participants was to explore more about the screener's purpose, the use, the challenges, and recommendations. The study employed a qualitative design informed by interpretive description, a methodology well-suited for generating practice-relevant insights in applied health research. And we had obtained approval from the UBC Behavioral Research Ethics Board. The characteristic of the participants, we had 13, and their roles included social workers, registered nurses, registered psychiatric nurses, and leadership members. The clinical experience ranged from 3 to 40 years, but the time actually worked at the Access and Assessment Center varied from 6 months to 7 years. The diversity of the participants provided a comprehensive perspective on this MHSU screener's impact in clinical practice. So we're just going to talk about the findings of the study. So the first finding was the perceived purpose of the MHSU screener. So participants thought that the screener was actually used for data collection to collect individual client data and for program evaluation. As in terms of clinical utility, the screener itself the purpose is to aim to guide treatment planning, but it was often seen as being underutilized. The participants also felt that the screener the purpose was more for administrative functions. They felt that it was to help to support funding by entering information and to help with program development. Overall, there needed to be clearer communication regarding the screener's purpose. The other finding was about their feedback on the training. So they felt that there was insufficient initial training and lacking depth and rationale to understand why they were asked to use this tool. There was a need for more detailed and purpose-driven training, as well as they felt there was a lack of consistent follow-up and monitoring after training, so to have more of that sustainment piece. They also had views on the actual screening questions. So one of the issues that was across the board was about the usability, particularly the tick box format. So here I just have a screenshot here of just part of the substance use assessment. So here, the clinician would tick what is the primary problem. The issue with this is that if you have a client who has polysubstance use, they're using multiple substances. So it's not just one substance that's the primary problem, it's multiple, but you can only tick one substance. What also is also problematic was it mentions about the total number of times it's used in 30 days. Well, if someone says that they used it 5 times in the last 30 days, that's different than if someone says, I've used 5 times in the last 5 days, which would show that the substance use pattern is very, very different. But with the format of the way this tool is, it's quite rigid and doesn't permit for that. Clinicians also felt that there needed to be more specific and detailed questions. They felt that the question structure needed to be revised so that to add more detail to capture the complexities of the client's substance use patterns as well as mental health issues. There also was a preference for flexible narrative input options. The participants had familiarity and experience, comfort, while some preferred traditional narrative-based assessments as a more genuine and effective way of gathering information. So a quote from one of the participants was, I prefer the narrative. I feel like it's a bit more genuine. Another finding was about data capture and transfer challenges. So there's difficulty in capturing the detailed information and quantifying substance use. So I just have a little screenshot here where it says like the typical amount that's, for alcohol and tobacco. That's a little bit easier to capture. So if someone says, oh, I smoke a pack of cigarettes, I smoke 10 cigarettes a day, or I have 3 bottles of beer. But if you have an individual who's using other substances, if a client says, oh, I use 1 point, or they use some other form of jargon, it's very difficult for the participants to know how do you translate what is being said into an actual amount. And what they felt was that they needed some kind of scale or matrix to be able to define. If someone says, I use a point, what does 1 point mean? Or if I use like half a bag or a quarter of a bag, what does that mean in actual amount? So I have another quote here from a participant. I don't see any issues with the questions themselves. I have more with issues with how we input in the information. One thing I find difficult is that when it asks you to list an amount, it's very hard to determine amount with certain substances other than alcohol. And also as well, the participants felt there was issues in translating the qualitative data into the screener's format just because of the rigidity that's in there. Also, one of the challenges was navigational issues in PAIRS, which is the clinical information system that the Access and Assessment Center utilizes. So in terms of the screener, it's actually found in the assessments module, whereas majority of the documentations is found under the case notes. So sometimes what the participants said was that sometimes they would forget that, oh, the screener's actually under assessments because they're used to doing all their documentation under case notes. And then the other finding was about the impact of the MHSU screener on referrals. So the participants felt that there was a lack of specific referral information within the actual screener. So for example, if let's say a clinician ticked, refer to mental health or substance use service, there was no actual text box where you can add more context of what that may be and such. Also, as well, it was felt that the screener's contribution to referrals is not easily noticeable. I think it's important to note that the Access and Assessment Center has a template that they use to guide and document assessments, and the participants felt that the core questions that are asked in the actual screener is already integrated into their own intake assessment. So as a result, there was a perceived redundancy when the screener and intake assessments are used. Also as well, referrals are often based on professional judgment rather than the screener itself. So limitations with our study was that the sample size was drawn from one site, which can limit transferability of insights to other sites and geographic locations. Our sample size was 13. Sample size may not capture the full breadth of experiences across the system, and our study focused more on the clinician's perspective. If client or managerial viewpoints were considered, they might offer insight into the screener's role and impact. Next, I'm just going to talk about suggestions for improvement and conclusion. So the participants had some improvements that they had suggested. One was to create actionable items from the screener, such as direct connections to specific referrals. So if they were to make a referral, it would be ideal that they could make the referral within the clinical information system that they use instead of having to use paper and fax and so forth. Also, to enhance the screener to include more detailed referral information and to improve integration with existing assessment tools and systems that are utilized. The second suggestion was enhanced training and support. So implement robust initial training programs explaining the screener's purpose, the benefits, and the workflows. And then introduce ongoing training to maintain proficiency and sustainment. And lastly, to integrate training to onboard new staff. The other suggestion for improvement was improving the usability. So revising question structure to include more detailed queries, such as withdrawal experiences and substance use patterns, introduce more flexible response options, including comment boxes and scales for nuanced experiences, as well as integrating the screener with other electronic health record systems to avoid redundancy and ensure accessibility. I also want to note that the findings of the study have been presented to the regional mental health and substance use executive, and who are currently reviewing the MHSU screener and deciding on the next steps. So I'd just like to to close, the study was a bit of a roller coaster because I didn't know that there was going to be a pandemic and the impacts of it. But I think that if there's anything that you want to do that might be perceived as maybe doing hard, I think research also is perceived as being something really hard. If you stick to it, yes, you're going to have roller coasters where you're going to hit roadblocks and there's going to be these sparks of light. But if you stick to it, you'll see it to the end, and you'll have amazing, lessons learned that you can apply to. So I just really want to acknowledge the Vancouver Coastal Health Research Institute for their team grant funding. I also want to acknowledge the Access and Assessment Center leadership for the support of their study, as well as the leadership members who participated in our study, as well as the Access and Assessment Center clinicians who participated in our study, and most importantly, the clients whose interactions with and experiences at the Access and Assessment Center who provided valuable context for clinicians using the mental health and substance use screener. Thank you.
Awesome. Thank you, Sue. Let's open up the floor to questions. Maybe Tom, I'll go to you first for online.
So is someone commented, ICU nurses commented that it's incredible work from your experience as a nurse leading an interprofessional research team. What is your advice? What was your advice for aspiring nurse researchers?
So my advice for aspiring nurse researchers is don't aspire, just do it, right? So whether if you don't have experience, you can look at things like doing the Vancouver Coastal Health Research Institute has things like the KT Challenge. Sometimes they'll have the team grant. You can start somewhere small, right? And then where you can get like mentorship and supports, and then you can go from there. Sometimes we have these like ideas of being like, hey, I think I want to learn more about X. Like instead of saying, I would like to, it's like, let's do it, right? And then, recognizing that anything that we want to do, we always think it's like, oh, such a smooth ride, riding up to the hill. Of course not, because we just get stuck in the middle of the hill because there's some obstacle. But then in some ways, having these obstacles really helps, as in terms of, it's a test of your patience and resilience, but if you can get through, you'll be like, yes, I can see that what the light is at the very end of the tunnel. So I would say is don't give up, like follow your dreams. And instead of saying it's a dream, make it something actionable. I used to have this phrase that I used to say when I used to work with clients, I would say to my clients, like, how do we go from I can't to I can? So anything's possible.
Great. Any questions in the room? We have a couple minutes here for questions in the room. And if you have a question, please use your mic. I'm told there's a way to unmute it. So there you go. Questions? Awesome. Oh, wait, Lori has one.
Is there a place you think down the road where form design could be supported with like generative AI that might scan the patient chart and prompt some supportive responses that could help a clinician determine how to fill in whatever revisions you're providing?
Totally, for sure.
Okay.
And I just also like to just say that my research assistant, Cattle, is here today and in person, and I just really like to acknowledge him. He's at the far back there. And I really just like to thank him for sticking with this. It's been a roller coaster, and him and my other investigator, Mohammed, I couldn't have done it without them. So thank you.
Amazing. Awesome. Thank you, Sue. Okay, so next up we have our group from Coastal. So as they're making their way down, just wanted to welcome Gab, Stephanie, and Kelsey, who are here to share their work that's ongoing to advance nursing practice for rural and remote nurses on the use of nurse-inserted supraglottic airways. So welcome the Coastal Professional Practice team.
Are you happy to control? Sure. Okay. Hi, everyone. It's so nice to see so many familiar faces and new faces in this room. I can't see those of you online, but hello. And happy Nurses Week to everyone, just to echo the sentiment. I'm Steph. This is Gab and Kelsey. We are from the Coastal Professional Practice team, and we're here to just give you a glimpse into one of the many important projects that our team collaborates on to support VCH's coastal community of care. This one titled Nurse-Inserted Supraglottic Airways, a breath of fresh air for rural and remote nurses. We would like to start out by thanking you for inviting us to present on this incredibly important work of optimizing nursing practice in VCH's coastal, rural, and remote communities to include the insertion of supraglottic airways called iGels.
Instead of repeating the land honoring given at the start of the grand rounds, we want to take a moment to honor the lands of the areas our work affects the most. These areas include those located in the traditional stolen lands of the Nuuk, Heiltsuk, Shishal, Squamish, and Lil'wat peoples, and the treaty lands of the Tla'amin Nation. These areas have limited resources compared to the larger sites within VCH, like the one we're presenting in today. And we're so grateful for the opportunity to not only be here, but to present the work that we hope will have a significant and positive impact on the nurses' ability to provide life-saving measures and improve patient outcomes in these underserved areas. It's also our hope that by advocating for and implementing this project, we uphold and move forward VCH's commitment to addressing systemic racism by promoting equity of care across VCH. All right, so during our presentation, we're going to take you on a bit of a journey, starting with a little bit of storytelling and some background to give you a better idea as to why this work is so necessary. We'll then talk about the process of scope optimization, then document and educational material development, and how we plan to support this update in the coming months. Before we begin into the story, I need to let you know that the following story is fictional, and any resemblance to any actual persons, living or dead, events or locations is coincidental. However, the story is meant to be a representation of what it can be like working in a rural and remote site with limited resources. Let's set the scene. You are Julia, a registered nurse who works in the local hospital of your rural town. Your official job title is Emergency Department Nurse, but because of the size of the hospital and the kinds of services offered there, you are also the patient care coordinator, the discharge planner, the housekeeper, RT, lab technician, and pharmacy tech, and so on, all unofficially, of course. The town you live in is a very small one with a population of only about 2,500. As such, most of those 2,500 faces is familiar to you in one way or another. From the 4 grocery store employees to the hardware store owner to the only esthetician in town who also happens to be your neighbor. Change doesn't happen very often in your community, except for all the travel nurses who are constantly coming in and out for their contracted work time. Tonight, you are orientating a nurse who has never worked in a rural community before, and she is shocked to find out that the physician goes home at night. Even though they are available by phone, they are 10 minutes away, so the two of you are the primary responders to any emergency that comes through those doors. Tonight, you have been assigned 3 patients, one of whom is Mr. Brown, the husband of your child's grade 5 teacher. Mrs. Brown brought him in after dinner tonight when he complained of unrelenting heartburn. You recall attending Mr. and Mrs. Brown's 40th wedding anniversary party 2 weeks ago at the community center. Nearly the whole town showed up for it. Mr. Brown looked bright and vibrant that day, but tonight he looks like a different person as he lays on the stretcher in front of you. When you enter the care space to perform an ECG, Mr. Brown doesn't stir. With a closer look, you notice he doesn't seem to be making any respiratory effort, and his skin is a grayish blue color. You quickly check for his pulse, but you can't feel one. Immediately, you tell your coworker to phone the physician and report that you have a resuscitation on your hands, and you need them right away. You activate a code blue to alert the other nurses on site in the hope that anyone available will come help. You quickly flatten Mr. Brown's stretcher and initiate CPR. Your coworker joins you after calling the physician, sets up oxygen and an ambu bag, and inserts an oral airway. She begins to try and ventilate Mr. Brown between your sets of compressions, but there's no chest rise and his oxygen saturations are unreadable. She's unable to obtain a seal with the mask, despite multiple repositions and attempting to troubleshoot. You suddenly realize Mr. Brown's beard is in the way. A nurse from another part of the building has come over to help, and you ask her to start clipping his facial hair, but you already know he's going to need an advanced airway to ventilate him properly. You know this, but it's out of your scope to insert one. It's out of scope for everyone present. There's no respiratory therapist, and the physician is still at least 8 minutes away. For 10 minutes, your colleagues and you perform CPR on Mr. Brown, all the while unsuccessfully attempting to ventilate him. When the physician arrives, he immediately inserts an ET tube. Mr. Brown's saturations come back up, and your effective CPR results in a return of spontaneous circulation. Mr. Brown is stabilized and quickly transferred to a higher level of care. Unfortunately, the lack of oxygen during his resuscitation caused him to sustain an anoxic brain injury. He will need to be cared for outside of his hometown for many months while he recovers enough to hopefully attend rehab. The entire community, including yourself and your colleagues, is deeply affected by his absence and by the whole event, and you can't help but wonder why there wasn't more you or anyone working that night could do. Although this situation is a work of fiction, from the location described to the image of this lovely couple who was pulled from stock images of, oh, we skipped already. Sorry. That couple was stock image from Canva. It hit home for a lot of nurses who have experienced a similar sense of helplessness. When situations like this one described in our story arise, the combination of employers set limits on nursing practices and a lack of available team members for whom those activities aren't restricted creates a lose-lose situation for both patients and nurses. With consistently limited resources, like in rural and remote communities, the odds of these lose-lose situations occurring are particularly high. The purpose of our work is to reduce the number of those situations by presenting nurses in the rural and remote communities of coastal with more options, one of which includes the ability to insert an iGel. This will, in turn, reduce inequities and improve access to care in these underserved areas.
So in VCH's rural and remote communities, limited access to respiratory therapists means that the management of an advanced airway falls to the point of care providers. When they're not available, nurses have to step in. And currently they're limited to basic interventions like inserting an oral airway and using the bag valve mask ventilation. And while manually bagging a patient can be life-saving, it's not without its challenges. Take Mr. Brown's case, for example. His beard made it nearly impossible for Julia to get a proper mask seal, leaving her unable to adequately provide him with the oxygen his body needed in this critical time. Other common barriers that might disrupt the success of this technique include facial abnormalities, obstructions, or even just a lack of experience. And so in theory, switching to a two-person technique could help, but in these resource-limited settings, an extra set of hands isn't always an option. And then there's time. In rural areas, delays in getting help or transferring to a higher level of care aren't just inconvenient, they're critical. Prolonged manual bagging is physically exhausting, and ventilation quality often drops over time. When every minute counts, these gaps in airway support become dangerously clear. These complications put patients at significant risk for poor outcomes. So it was largely through the engagement with the coastal, rural, and remote educators and hearing their stories very similar to Mr. Brown's that we learned how optimizing scope of practice for nurses to insert supraglottic airways, specifically iGels, would not only better support patient care during these critical situations, but they'd also reduce nurses' stress when they're unable to establish effective ventilation with bagging. And while intubation with an endotracheal tube is clearly stated as not within nursing scope, largely due to its complex placement in the trachea, iGels are placed above the vocal cords and in the pharynx and offer an excellent and feasible alternative to airway management in the short term. So why iGels? In VCH's rural and remote emergency departments, iGels are the supraglottic airway that are currently supplied. So that's an easy one. They already exist. Unlike traditional laryngeal mask airways or LMAs, they're stiffer and they require balloon inflation. The iGel features a soft gel-like cuff that doesn't need to be inflated, making it quicker and easier to insert. And the design is especially helpful in both routine procedures and high-pressure emergencies. iGels are known for being user-friendly and providing effective ventilation even during CPR. They also tend to have a higher first attempt success rate compared to endotracheal intubation, and they're the fastest and most reliable option for blind insertion. So this makes it particularly helpful for nurses or providers who may not have extensive airway management experience.
Great. So was it possible? So first we investigated whether the skill is within the scope of practice for RNs by referring to BCCNM. We found that according to BCCNM, RNs are permitted to perform iGel insertions and may do so without an order in cases where a provider is unavailable and this treatment is essential to survival of the patient. However, this would require additional education and guidance from the health authority. Therefore, without education and outlined limits and conditions for the skill, it was not within the scope of practice for nurses prior to this project. Next, in order to align practices with other health authorities and to leverage existing resources, we completed an environmental scan of other BC health authorities to identify if RNs are performing this in any other areas in BC. We found that in Interior Health, Northern Health, First Nations Health Authority, and Vancouver Island Health Authority, RNs are performing this skill to meet patient needs. These health authorities also serve many rural areas with complex clinical environments. Their resources and guidance supported us in developing an education plan curated to the needs of our communities. So why rural and remote? Coastal, rural, and remote sites operate differently than urban sites, and even compared to each other. Their geography, site, skill mix, and access to resources make them each beautifully unique and requires thoughtful consideration when planning large-scale implementations. The rural and remote sites within VCH have a variety of differences compared to their urban counterparts, including but not limited to RT coverage, if any, RN as first call, heavy reliance on travel nurses, and limited on-site provider coverage overnight. Each site experiences some of these challenges, and unlike urban, where there is a variety of people to call in an emergency, nurses are often limited to the expertise of their peers to provide timely and quality patient care. To meet the care needs of adult, pediatric, and neonate patients, our focus is emergency, critical care, and maternity RNs. Right now, this includes over 200 nurses within VCH that will require this education. With rural and remote retention and recruitment strategies, we anticipate this number will grow. They didn't even plan that. Initiatives like these lead to more equitable care for people living in rural and remote areas by offering innovative solutions and exceptional care that ultimately lead to healthier communities. So SPRC, Scope of Practice and Regulation Review Committee. So since this was not permitted in VCH yet, VCH Scope of Practice and Regulation Review Committee needed to approve this change. This group of professional practice, clinical education, risk, legal, and operations partners collaborates to decide if scope can be optimized upon request and support defining limits and conditions to these optimizations. Knowing that this change was incredibly important to point-of-care clinicians and was a step in delivering timely patient care, we submitted a request to SPRC outlining the clinical drivers, project plan, and the limits and conditions. Understanding that this would be a practice change, our team knew that a comprehensive education plan was crucial to the implementation and sustainment of this initiative. Thank you. So SPRC conditionally approved iGel insertions for RNs with the following limits and conditions. So this will be limited to rural and remote EDs, perinatal areas, and urgent care centers. The conditions are that RNs must have specialty training, so in emergency, critical care, or perinatal, and they must have the required life support certification appropriate to the specific population. This would include ACLS, PALS, and NRP. A decision support tool must be available, and RNs must receive additional education to perform this skill. So that's where we came in. Our team created a decision support tool to outline site applicability requirements, limits, and conditions, and the procedure of inserting an iGel. Recent literature, Elsevier, skills, and other guidelines supported the creation of this DST. The document required extensive peer feedback and collaborator engagement, and it went through VCH's rigorous DST process. It has finished first read, and it will be going for endorsement read soon.
Okay, so turning to the education plan. As Gab mentioned, we needed to ensure development and implementation of an education strategy that aligns with the DST and supports the practical application of inserting an iGel. It's been essential for us to engage with key partners throughout this entire process. Nursing professional practice, RT professional practice, the regional interprofessional RT educator continue to help us ensure this work aligns with both professional accountability and clinical practice recommendations. And probably most importantly, our subject matter experts, the CNEs who recognized this as a critical gap in rural and remote patient care and initiated this request for this optimization. They'll be imperative for ongoing education and sustainment phases as practice reaches the point of care staff. Thank you to them. in advance. So developing the education plan. This was kind of the fun part, really kind of grounding the work in adult learning principles. We created a curriculum that provides multiple accessible and practical learning methods to support the skill development and maintenance in alignment with the DST. So we are in the process of developing a learning hub module. The course will outline the foundational requirements for scope, along with overview of preparing, inserting, and ongoing care and management and discontinuation of an iGel. And we'll use this course as a component for yearly competency maintenance. We have developed a lesson plan that comes as a package of resources, activities, and presentations to support the CNEs in delivering this education in various ways. This might be for education days, for huddles or in-services, or integrated into their orientation, clinical laddering, or onboarding processes. It includes a PowerPoint presentation with speaking notes, a quick reference guide for documentation, an infographic outlining the key components of the DST, and a lanyard card for quick reference to sizing guides and tips for ongoing management. We will also provide a competency checklist for self-assessment to assist with competency maintenance. And then for practical application and demonstration purposes, we built out some simulation scenarios that are relevant to rural and remote settings, emergency situations in these settings for adults, pediatrics, and neonatal populations. So we understand that implementing this education strategy will be an ongoing and iterative process. We're not quite there yet, but the initial rollout, all eligible staff will participate in the education program, which will be continuously refined through PDSA cycles, incorporating the feedback and the lessons learned through the process. As the program matures, our focus will shift toward long-term sustainability by embedding the content into new hire onboarding, clinical ladder advancement, and ongoing competency maintenance, as I mentioned. Recognizing that skill retention requires continuous learning, the coastal professional practice team will continue to provide support during the initial onboarding at our coastal, rural, and remote sites. And then we will also include a train the trainer setup so that our educators and super users will be well-versed in continuing this education, and will support that process along the way.
Okay. In conclusion, by equipping rural and remote nurses with this vital skill, we aim to change the trajectory of stories like Mr. Brown's so they don't all end the same way. This initiative not only improves patient outcomes, but it also empowers nurses with the confidence and capability to act decisively in critical moments. The result? Safer care, stronger teams, and a health system where everyone, nurses, patients, and the entire Vancouver Coastal Health Authority can breathe a little easier.
Thanks so much for joining us today and inviting us to this platform to be able to share this work. It's been such a labor of love, and we've put so much time in the past year working on this project, so thank you.
Okay. Oh. Thank you, guys. And just wanting to hold my hands up to honor the work that you guys are doing. I was just up in Bella Coola, and it is such a beautiful place, but it is very, very different than what we have here within Vancouver General. So amazing work, and people will benefit. Very great. Wanted to open the floor for questions. Maybe Tom again. Anybody online? Takers? Excellent.
Thank you to whoever that was from.
Yeah, Tom just said congratulations on the extraordinary work, just for folks online. So thank you for sharing that. We have a question in the room. Just remember to unmute your mic.
First of all, congratulations. I know this is a thing that Lionsgate has continued to try, so for you guys to actually accomplish it is huge. Thank you. I guess my question is around the language that's going to be included in the DST, because I know that there have been differences in interpretation when it just is outlined as additional education, and then things fall off and become kind of like unit or site specific, and what your plan is around that.
They're very detailed in the additional education portion for this, being especially like a new skill that we're introducing. We've been very comprehensive in what we've included. And we will be sharing the resources that we've made. And there's also going to be a competency checklist in there for self-assessment.
I think too, like just so much of the work that we do within the coastal community of care is, as with everyone, but like we have really deep connections and relationships with our partners in the rural communities. And so, I mean, I'm quite confident that they will not hesitate to reach out should they need any, but as I mentioned, it will be like very well outlined.
There is, sorry, one chat question. Let me scroll down. The ICU nurses are curious if your team has connected with CCBC or the Provincial Emerge group. Alana, I know you're there.
Questions coming from Alana.
Please reach out to the team.
I have a question.
Oh, yeah.
So we recently had a code orange. So in situations, even in the urban centers, would this be a good tool for people when resources are thin in that short period of time?
Yeah, so right now we focused on rural and remote, but hoping that in these situations that this can be optimized in other areas, and that urban can also like leverage what we've created to hopefully integrate this into their practice at some point.
Hope is maybe one day this work can be used as a little bit of a blueprint to excel other areas.
Go ahead.
It's come up in conversation.
Yes, Steph and I,
Sorry, just for folks online, the question was, are they considering publishing?
Yeah.
Which you should. Just saying.
Steph and I just both finished, and Kelsey, our masters, and thesis work has been done, so we're thinking about it.
This means that you're well versed in paper writing.
Yeah.
This should be easy, right? Your practice, you know how to do it.
Yeah.
Awesome. Any other questions in the room?
Thank you so much for that presentation. It was terrific. I'm curious about how you plan on evaluating the success of this rollout and what sort of like ongoing monitoring of, I guess, like adherence to your plan.
Good question. So when we started this project, I was looking into what data we can collect to kind of support that this is needed. And it's really hard because rural and remote does not have as much data as we do here. It's like hard to even find like really, really simple stuff. And so it is really important for us to like make sure that we're maintaining competency and how we can record how many of these insertions are actually happening. So we've been also doing work with our recess teams at each of these small sites, and these have recently been launched. So we're hoping to integrate some of that data collection into there, as well as, looking at like staff surveys and, maintaining our collaborator engagement with our educators to make sure that this is usable, and if we have to make any updates and changes as we kind of go along. But due to the lack of data, this is kind of, we'll see. And
I think like the initial evaluation will be very much focused on like the education and, is it impactful, is it relevant, are they getting enough practice and those kinds of things. So
the Cerner is also coming to that in a few months. So I think the hope is too that there's going to be additional areas for data collection in a more concrete sense. But I think there's also the opportunity to evaluate things the same way that, or in a similar way that we'd identified the need in the first place, which is conversations, conjectural, a little bit conjectural, and just ongoing evaluation through that avenue.
Yeah, go ahead.
I'm scared to press the button because I know the camera's coming. I just want to say hats off. This is absolutely amazing work from the coastal rural team, for rural and remote, sorry. I'm learning a lot from you guys. So thanks for sharing it. I couldn't be more proud of it. My question for you guys is really that partnership piece regards to like when you start collecting that data. Have you considered partnering with the Airway registry? So that's one of your data points on who's putting them in and where.
We haven't yet, but that's a really good point. Might pick your brain about that later.
I'm not sure that it's used as often in rural and remote, just judging on some conversations I've had with some of the physician groups with the resuscitation stuff, is that kind of like those working in urban sites are aware that it exists, and maybe there needs to be some more.
I agree. I think there is that challenge with compliance with physicians documenting, but I'm curious if it's part of your competency with that, if that's a way to get that engagement piece would be a neat way to really stay on track for that pro-nursing like scope advancement.
We are working with Cerner to change the documentation for pharyngeal airways, I think it's called, and then there's a drop-down menu of different kinds, and they have LMAs listed there, but iGels are in fact different, and so that we've asked for that to be included, and so I'm thinking maybe we could also who inserted it. Thanks for brainstorming with us.
We're nurses, it's what we do. Any other questions? Just appreciating we have 1 minute left. No. Great. Big thank you. Thank you to you guys. Thank you for coming. And thank you to everyone for attending our second Nursing Ground Rounds. Very excited to see that we have folks here. We have lots of folks online. It really shows that there's a need and a want from the nursing side of the house to have information and to be able to share some of the projects that are being done across our health authority, which is amazing. So congratulations to our presenters for presenting today and their amazing work. We do have an evaluation, so please tell us how we're doing. Please let us know if our sessions are meeting your needs or not. And if there are future topics, or if you yourself are somebody who thinks that perhaps one of your initiatives, studies, or plans in your clinical areas of practice is something that you would like to share at Grand Rounds, please let our team know. And if you do the survey, then you can enter to win a very lovely FIGS gift basket as well. So thank you very much for your time. We'll close it out. We are right on time at 2 p.m. Yay us. Happy Nurses Week, and go about your day. Thanks, everyone.